Frequently, the neurosurgeons will have a patient that has a neurosurgical and radiosurgical problem, and we work together to come up with a plan. Delineate the volumes that need to be treated, figure out the doses. We work with physics to figure out how to get the dose to the target, how to spare the normal tissue. And then after we treat the patient, to follow them and monitor them to be sure that they don't have any toxicities from treatment or develop any other new lesions that might need to be treated.
Each patient's treatment starts with imaging. Gamma knife is all about the quality of the imaging. Our preferred imaging modality is an MRI of the brain, which is the best way to count the tumors, measure the tumors, and then identify the structures around the tumors that we would want to protect from radiation damage. They're done in a way that those images can be imported right into our software here at the Radiosurgery Center. So if a tumor is identified, we can go straight from the diagnostic MRI to creating a treatment plan and then executing that plan within a few days. As long as we see the patient and tell them what they've got, we can go straight from that. And those images are brought into a software system that's part of the Gamma Knife platform. We sit at a computer, we draw them out manually with a mouse, we color them in, and then we look at it, decide how much radiation we're going to give it, whether we're going to give it in one bolt. Are we going to do it 3 doses of radiation in smaller doses and spread it out? Are we going to do it up to 5 times? And we decide how we're going to make it. Are we going to make it so that the radiation sort of spreads out a little bit on the edge? Are we going to hone it so it just hugs the edge of the tumor? And we also decide how much we're going to give the radiation. So a lot of our time in Gamma Knife, truth be told, isn't spent with the patient. It's spent in front of a computer drawing out and creating plans and things like that that allow this machine behind me to do what it does and deliver the radiation in the precision way that it does. There's a huge vault back there that opens up and has this conical thing that has these 192 different collimators that are divided into 8 sectors, and those collimators can be opened to various widths. When they're open, they're either 4, 6, or 16 millimeters. So when you have 192 divided by 8 with all these different shapes, you can create all different contours and shapes of the actual dose of the radiation that's coming out of that machine. The Gamma Knife is precise down to about 0.3 to 0.4 millimeters. So when we make a plan and we say, well, this is where we want to treat, the average margin of error is about 0.4 millimeters, which is, a fraction of an inch. And the way that we do that is that the machine has the ability to cut off at the first time if it senses the patient's moving at all. Furthermore, this thing right here is a CT scanner, and that goes around the patient every time and re-references the patient's anatomy on that day to the plan that was created to treat those tumors.
Today's planning environment for the Gamma Knife allows us to incorporate multimodal imaging into the treatment plan itself. We can register diagnostic images, preoperative images, post-operative images, and serial follow-up imaging into the planning environment, all in an effort to increase our precision, to target the intended treatment volume, and in today's management of cancer patients, plan ahead. This gives us the ability to save time for the patients in the frame on procedure day. The team, the neurosurgeon, the radiation oncologist, medical physicist, collaborate to incorporate the anatomic knowledge, radiation medicine, and radiation science into the finished product, a patient-specific plan.